If we start in 20 minutes.
Oh ya, Icanya ngomong apa gitu. Kalau mau pasti itu.
Hey, there's Warlicks.
John,
Hey, Warlicks, how you doing?
yeah, I'm good, but I still cannot like get my iPad. So I think that I cannot make it because it's I have to do it on my iPhone.
Hold on, hold on. Just seconds before. Oh, okay. Okay, what's that, Warlicks? What'd you say?
I saying that I cannot get my iPad because I still out of the hotel, and I think I cannot do it officially because I have to do it on my
Let's try it.
iPhone.
Let's try it. Let's try it right now. Let's see how your picture looks. Put your
Okay.
camera on and let's see how it looks. Maybe it's okay. Let's check it out.
Yeah.
Okay, yeah, let me take you. Okay, go ahead, Wallace. Go ahead. Talk.
Yeah, I'm talking now.
Yeah. Well, okay, keep your head centered. That's good. You could do it right. That's fine right now. You want to do it?
I don't know. I kind of like, I mean, I don't think it's like proper or appropriate.
Well, it doesn't look too informal. Yeah, maybe you're right. Okay. So yeah, I'll just introduce Juan Lee because he's the only one you need to introduce. He's a Chinese host.
Yeah. I'm so sorry, but I think that
Yeah, I think you're right. I think you're right. It does look
Yeah.
looks a little casual.
Yes.
Yeah. So I think it's probably it's not a really serious, but I mean, we have a certain level of decorum.
Yeah. Sorry. So I kind of like, I think
Well,
it's
look,
like
the sun is coming down, huh? Oh, the sun's coming up. No, coming
no,
down.
it's coming down. Yeah.
Geez, I
And
wish you. Juan Lee,
yeah,
how
maybe,
you doing?
Hi.
yeah.
Yeah.
Oh, okay.
Okay. Yes.
Yeah, this is Warlicks, meet Juan Lee.
Oh yeah. Oh,
She was gonna host, but she's on the beach.
wonderful.
Yeah,
Wonderful.
show Juan Lee the beach. Show Juan Lee the beach,
I
Warlicks.
saw it actually. Yeah.
And he'll see why you're there.
Is that?
It's in Thailand, right?
Oh, Thailand. Wonderful. Oh, I saw it's Hawaii. Oh no.
No, Thailand.
Wonderful. Oh.
Well,
Yeah,
I wanted Warlicks to host. I said you can't eat on camera and you can't do aerobics. So she goes to a resort and I can't, and she can't, we're supposed to be serious here. You can't. So I agree with her. It might be good for her to wait till the next webcast. Okay, so I'll introduce you, Wanli, okay? Then you run the show, okay?
Yeah, I think actually today, the main speaker will be Ali, right? From Little
Okay,
Rock.
yeah.
Yeah.
Should I introduce Ben first or you first?
Oh, both. No, never mind. Yeah.
Okay, I'll just introduce you and you just do what you want to do.
Yeah.
Okay.
Good.
Does that sound good?
Super good. Actually, how to.
I gotta make sure, oh, here's Ben. I gotta make sure I get the speaker in. Yeah, I'll make you co-host, okay?
Okay.
That means you can admit people. If you see someone that needs to be admitted. Well, Warlocks, maybe you can co-host and keep people, you know, behaving. Oh, Ben's not in yet.
I see Dr. Chris here.
Yes, yes. If you see anyone in the panel we think needs to be Wanli, we have to admit the speaker, right? Zia Lynn. Oh, where's Victor? Yeah.
Hello, good
Hey,
morning.
good morning, Margarita. Good morning, Ben.
Hi, good morning, John.
You get in okay, okay? That's right. So I'm going to introduce Wanli and then he's going to run the show, okay?
hmm
Yeah, Ali's here. Ali, are you here? You get in early, an hour early to make sure.
Yeah, good morning. I'm here now.
There he is.
Good morning.
Good morning, Zoo. How are
Hi.
you?
Fine. How are you?
Good to see you.
Good to see you.
Yeah, we start in 8 minutes, Ali. Okay. Ready? 8 minutes, Ben. But you want to see the beach, Ali, in Thailand? Warlocks, are you still there?
Yeah, I'm here.
Warlocks, are you there?
Oh, yes, I'm
Yeah,
here.
go ahead. Show Dr. Chris the beach in Thailand.
It's really not appropriate.
Oh,
Yeah,
That is
she's a
painful.
neurosurgeon from Thailand. She was going to moderate today, but she's at the beach.
Oh my goodness.
Yeah.
That's a beautiful spot.
Yeah.
Oh, yeah,
guess-
welcome to Thailand. It's in
Thank you.
Phuket.
That's
Okay, right.
yeah. This is where the tsunami was, huh?
I just come from for vacations, but I think that it's a good time because our government just canceled all the Thailand pass. They
I
do
see.
not have the restrict control now. So yeah, and during this time, there's not many not many tourists come yet. So yes, it's quite a good
I
time.
see.
I'm really so sorry. It's not like appropriate.
This is
sorry.
this is sunset, huh?
Is that expensive there, Warlocks? Is that you're at kind of a resort, right?
It's very nice hotels and very private. So and right now it have a big discount. Yeah. So I think that
Show us-
it's win the most luxury hotel award for many years. So if you guys want to
Can
take
you
a
show the
trip,
hotel? Can you show the hotel?
my hotel it's kind of like each of the house up
It's
to
not
the
very
hill.
crowded, huh? Nobody there.
Yes, very private.
Wow. It is private, totally private.
Yeah, we yes. So yeah. So sorry. Yeah, so sorry.
Okay. Is Zealand in yet? Zealand, is he in? Ben, is he in? Do you know if he's in? Hmm. Hmm.
Good morning, Kylie. I see you are here.
Yes, yes, Professor.
Good.
Hello, Charlie.
Yeah, good morning. Good morning,
Good
Professor.
morning. So you're still in Little Rock?
Yes.
Okay.
Kylie is doing a great, beautiful job.
Yeah, I know. So you keep him so long.
Yeah, yeah.
You won't let him go.
We need more of Kylie in Little Rock.
Yes. So
Oh,
he also get a great opportunity to work with Professor Krisht.
Dr. Tsai, right?
Yeah,
Yeah.
Charlie.
Yeah,
Good
actually,
morning.
yesterday, the day before yesterday, I had dinner with Dr. Long Jiao, right?
Yeah, it's my teacher.
Yeah, he talked about you. Wonderful. Oh, Ali, yeah.
Wanli, can you move your camera up a little bit so we can see your whole head? Because we're just seeing the top part of your head. Yeah.
Really? Oh,
Yeah, that's better. That's better. That's better. Yeah.
All right.
The last webcast we have, I was so mad at myself for not saying anything and waiting. It was too late. So now we get to see your whole head this week. So Ben, you do the Japan web chats also, huh?
Yes.
You're a busy guy. That's mostly Saturday, right?
Yes, we have the ACNS webinars
Oh, okay.
twice per week.
Twice a week.
On Wednesday and Saturday.
Okay. Yeah, we're starting Henan Grand Rounds. U.S. hospital.
Yeah.
But U.S. I don't know if he's going to participate.
Professor Krisht, is there any problem because of the pandemic for your work?
I think now it's winding down. It's getting better. So, but we have a unique situation because our hospital is predominantly a neurosurgical and neurological center. So we have another hospital, a sister hospital, which took all the COVID patients. So when the patients come to us, if they are COVID positive, they go to the other hospital. So this helped a lot keep us out of the epidemic in a way, the pandemic. Yeah.
Great.
So we stayed busy. I know a lot of hospitals in the States, they stopped doing elective surgery.
Yeah.
We did not. We kind of stopped the very elective, like somebody who has back pain can wait. But meningiomas or aneurysms, we didn't wait. So.
Yeah, Ben, we'll have a good amount of time to talk about the center, right, in Arkansas?
Yeah.
Yeah, well, that's good. I'm sure the Chinese neurosurgeons want to know about it. The ones that don't know about it. Are you ready, Ben? And ready, Wan Lee?
Yeah, I think.
Okay, hold on. Let me introduce you first, okay?
Yeah, Bing, you can
Okay.
introduce Ali at first, and I can introduce the second speaker.
Oh, you want to introduce Ali, Ben?
Yeah.
Yeah, I prefer to have a neurosurgeon introduce him. Okay,
Yeah.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the 5th Chinese Neurosurgical Journal webinar. And let me just turn it over immediately to Ben Zhu. Welcome, Ben.
Thank you. Thank you, John, and good night, because in China it's night. Now let's invite the first speaker, Professor Ali Krisht. Professor Ali Krisht is a very famous neurosurgeon in all of the world, and his mentor is Professor Yasaja, and the rank. So Professor Ali Krisht is very good at the Cavernous sinus approach for this kind of I think he can do so many neurosurgeries and especially in the Cavernous sinus operation, he got a world famous achievement. So now the time is yours, Professor Krisht.
Thank you, Zhu. Okay, John, can you see my
Yes, perfect.
screen? Okay. All right. Well, thank you. Good evening in China, and good morning to whoever is somewhere else, and good afternoon to whoever is somewhere else. So, and thank you for the invitation. It's my honor to talk to your audience. And again, John, congratulations on persisting and making your webinars as a major source to all physicians at different levels, from the student levels to the professor levels. This is commendable. And I follow a lot all the things that you've been doing, and I'm sure it has a great impact to places where they have less exposure to what's going on in other parts of the world. So congratulations. I chose this topic or this title because I am very comfortable to say that nowadays surgery in the cavernous sinus is a very safe thing to do. Now, I know some people will think what I'm saying is crazy or wrong or exaggerated, but that's okay. This is what happens a lot of times when something is new and different and it's a change. Most people resist it or they don't want to believe it. There's also the trend of, and you have to be careful when you hear people talking about the cavernous sinus, there are those who who may claim knowing the cavernous sinus, but they really don't know it, or they don't know it enough. So they have the tendency to undermine anything that looks like it is kind of showing that things can be done a little bit more than what they have been doing, because they had difficulties. And because they had difficulties in dealing with the cavernous sinus, they feel like it's impossible somebody else can do it, because if I cannot do it, nobody can do it. So all these things have to be factored in. But first, we have to also have clarity about the cavernous sinus. There are the big advantage for dealing with the cavernous sinus is, number one, it's a great highway that leads you to a lot of other pathologies and makes what used to be very difficult very easy. So you need to navigate the cavernous sinus so you can get to other pathologies and achieve much higher and better results. The other aspects of it is operating within the cavernous sinus. And to define this, I can tell you pituitary adenomas are not difficult to operate on. They are relatively the easier one, but again, they have their own specifics because they start outside the cavernous sinus. Chordoma is the same. They start in the bone around the cavernous sinus, they go into the cavernous sinus. Meningiomas is different. There are meningiomas that start outside the cavernous sinus and they go inside, but there are meningiomas that start in the cavernous sinus. And these are, to me, the ones that once you conquer, then you conquer the cavernous sinus. And for those, it's important to also know how they are defined. And it is easy to look at some publications and you can see a tumor like this and somebody will say, this is a cavernous sinus tumor, and it's published. And this is a problem because, number one, the one who published it didn't know that this is outside the cavernous sinus. And number two, the one who reviewed it and accepted it to be published assumed this is in the cavernous sinus. Another examples like this case, which is also published as in the cavernous sinus, or case like this published in the cavernous. These are not cavernous sinus lesions. So it's important to have a clarity to where the pathology is, because if we don't understand the pathology and how it distorts the anatomy, then the surgery will be futile. It's like you go in and you spend a little time and you say, oh, this is a difficult case. I always say there is no difficult case. A difficult case is equal to a surgeon who's not prepared. When you are not prepared, it's difficult. And if you ask any one of you, you ask yourself, if you ask, Dr. Zubin, at one time, he probably thought bypass surgery is difficult. But then now he does 6, 7, 8, 9. He told me that his record was 9 bypasses in one day. Why? Because he mastered it, he understood it, he unfolded all the little things related to this procedure, and he got the right team, and then it became an easy one. So if you look at, this is another publications, and you can see even the way the picture of the cavernous tumor is wrong. The nerves are never inside the tumor. They're always on the surface of the tumor. And the only one that's inside is the sixth nerve. So to conquer the cavernous sinus, there was two main challenges that you have to overcome. One is the carotid artery and one is the sixth nerve. And the sixth nerve was conquered already, and I will show how this can be done. But the carotid is our last battle. So I'm starting with the description of my title in a way. Now, we have to, every time we come to the same problem, we have to progress and we cannot give up on it. And this is a good example. This is Professor Eisner being asked is, he gave the same test, the same question this year. So he said, the answer is different. So if you go to the cavernous sinus, you have difficulty and you leave and you say this is difficult, and next year you treat it like a difficult and you don't assume the answer will be different, then we're not going to progress in a way. And that's a mistake that happens a lot. over time, we make what we call standard of care. We say the standard of care for cavernous sinus is not to operate. The standard of care is to give radiosurgery. But then what happens when the tumor grows or even grows faster with radiation? Because there's a subgroup that Al-Mafti published about that they grow faster after a little while. So what do you do with these patients? You just tell them, I am sorry, you don't belong to the standard of care, so you are out of luck. You kind of lost the battle in a way. So this is unfair. If this was your wife, your husband, or your loved one, then you're not going to give up. You have to do something. So a lot of what I was able to contribute, the little I contribute comes from my teachers, like what Zubin said. I have great many teachers, and we're very lucky to have encountered them, and they all work under the umbrella of the microsurgery of Professor Yazergil, who was my mentor and partner for several years. And I keep in touch with him every almost couple of weeks or so. And this is, as he said, Dolenko was one of the pioneers who was really pushed by Yazergil to operate on the cavernous sinus. And Professor Al-Mafti is the biggest influence I have, who I worked with as a partner, as a co-chair with him, and he was my teacher. And the late Professor de Oliveira, who was one of my main pushers, who always told me, don't give up. It is a lonely kind of road. Sometimes you may find a lot of resistance, but if you think you have clarity that this is good for patients, then you shouldn't give up. You keep going. So all these are contributors to what I've done, and I advise every young man to find good mentors and listen to them, and take every little details that they tell you. To be a master in anything, you have to be a master student first. That's the most easy and difficult thing, is to achieve mastery of being a student and stay a student. And then learning will never stop. Just if you are very eager to be important or professor or to be on the podium, then go and reflect and look at the mirror, because this is not how you can achieve good things for your patients. If you focus on the patients, focus on the real problem and the real message, instead of rushing to be on the spotlight, and then you are on the right track. So to deal with the cavernous sinus, it's important to define what we want to achieve. It is not normal to plan half a job, which is a lot of people do it. And I would like to say, divert a little bit. There's a lot of colleagues that when they are giving their lectures, they talk about the cavernous sinus, and they are experts and so on. I feel silent a lot of times, because what they don't know is they have told patients that we can only remove 60 or 70% of the tumor. But they don't know that these patients became my patients, and we were able to remove all the tumor. But they are sometimes on the podium giving a lecture, making big kind of statements about this is impossible to do, this cannot be done. But I reserve, the criticism, because my focus is not to fight. My focus is to fight the tumor, not other individuals. So the reality is different. So that's why it's important to be careful when you're listening to a lot of people who are experts. It's like looking at gold. Not everything that's yellow and shine is gold. You have to know where the real message comes from. So this is what half a job is. It's not incomplete, and it's not the perfect picture. And our goal is to be able to achieve as perfect a job as possible, because otherwise you postpone and make the problem more complicated, because a redo and radiated tumors are much more difficult. And you also lost the opportunity to save the nerves and to postpone the problem. For example, some colleagues will say, you know, if the patient have a partial sixth nerve, I will not do anything. If they lose all the nerves, then I will operate because you have nothing to lose. Well, you have nothing to lose as a surgeon, but the patient already lost. And this is not operating on yourself. This is operating on the patient. So the patient is losing. You're not losing because you don't want to look like you damaged anything. But this is a very bad excuse because you are saying, well, I don't want to be blamed for making a nerve not, you know, recover. But our job is to make it recover, and I'll show you the results later. If you operate early, when the nerves have not been completely damaged, that's the best time to reverse them, but you have to do the right operation. And the right operation has to be done by understanding the anatomy, because if you have a patient like this one, this is a patient like the examples who went to an expert, they operated on them, they took part of the tumor, they radiated, came back, they took a little part of tumor, radiated, and what you see is a tumor everywhere and the patient lost all their functions. To me, when they came, unfortunately, there's not much I can do. Now it's about survival. So we did clean the tumor well, but we did not improve on the functions of the eye because already the nerves are completely damaged from whatever happened before. So we don't want to be at this point. And this is a very common scenario, unfortunately. So this goes back to learning the basics. What are the basics? There's two things. One is to know the anatomy inside out. You cannot say, I know the cavernous sinus because I know, you know, this is where the V1 and V2, and this is where the fourth and third nerve. This is not how you know the cavernous sinus. The anatomy of the cavernous sinus has to be known at a very high level, and the very high level is when you understand two variations. The variation of the normal anatomy and the variations that occur during pathology. What happens to the anatomy during pathology? And then you have to make a plan that will go from normal to normal so that you don't cross through the pathology. Historically, a lot of colleagues went into the cavernous sinus. They exposed even intradural. They go intradural and they try to open the tumor, and they don't know where the nerves are. They don't know how they're distorted, and they start removing tumor, and all of a sudden they say, oh, this was the fourth nerve, and this was the third nerve, and this was the fifth nerve. And this is not how you do the surgery. You find the nerves first, and then the tumor becomes an easy thing to remove. So knowing the anatomy inside out, but not only this region, you have to know all the extensions of the anatomy, because you need to find the nerve from one end to the other, and they're constant at the brainstem, they're constant at the supraorbital fissure, like the third nerve, for example, in this case, and the fifth nerve with all the branches, and then you start bridging. So this becomes, the best example is when you're operating on peripheral nerves. If there is a tumor in the nerve, what you do is you don't find the tumor and you cut the nerve. You find the nerve and dissect it until you get to the tumor, and then you pull the nerve away, and then the tumor is gone in between. And so if you want to remember something from this lecture, remember that the dissection is from normal to normal, and then the pathology becomes easy. And you need to know where the little tumors come from. So for meningiomas, real cavernous meningiomas, not the ones that everybody will claim they are meningiomas of the cavernous sinus or tumor that extended. The cavernous sinus meningiomas start in this region. How I am sure? Because I have seen the progression. They start in this area, and this is where the fourth nerve underneath, the fourth nerve towards the sixth nerve, and in the petroclavial junction. This is why the majority of patients have a sixth nerve palsy among the earliest symptoms. The third nerve is delayed usually. Why? Because it's on the surface and it gets pushed. Fourth nerve, the same. V1, V2, V3, they can be involved early if the tumor is atypical and invasive. And then they spread in different directions. So they can go more this way or more this way, or more into the middle fossa or more to the posterior fossa, and so on. So operating on these tumors, I like to use this as a great example of how Michelangelo described the way he sculptured. He says he saw the angel in the marble and carved until I set him free. What does that mean for the cavernous sinus? Before you remove the tumor, you should see the final result. The final result is your understanding of the normal anatomy. If you can see the anatomy before you remove the tumor, then you start like sculpturing and bring the picture out in a way. So there are 4 phases of operating in the cavernous sinus. There's the exposure phase, then the extradural phase, the intradural phase, and the closure phase. Closure phase has to be as important as well, because if you look at our surgeries, I've so far operated more than 1,000 times in and around the cavernous sinus. We don't deal with CSF, spinal fluid leak, and all these complications, because to me, the closure is prepared from the exposure, from the beginning. Now, there are many steps to discuss, but it's not, we don't have the time. This is why we have courses. Like this year, we have a course in September on the cavernous sinus, and anybody who's interested can get in touch with me or Kylie, who's here, or Dr. Aboud. But the bony exposure has specific details to it, and then the extradural lateral wall exposure, because the dissection here is preparing the normal anatomy, and then you get the proximal and distal control of the carotid. Then the extradural part comes to the dissection of the nerves. If you see, it's all nerves. So I'm dissecting the oculomotor nerve next to the clinodal carotid, trochlear nerve starting from the superiorbital fissure going back into where it digs into the tumor, and then I stop. Then you define Parkinson's triangle, because this is what will lead you to the 6th nerve. And then you map the carotid artery, and then you identify V1, V2 and mobilize them. And then you establish the course of the abducens nerve. To do that, you have to know where V1 is, how it relates to V1, to the petroclival ligament, to the petrous apex, and to the wall of the carotid, the ascending carotid. So the 6th nerve is the most challenging, because it has many things to define. Then you can define where the 6th nerve is. And then you open and unlock Meckel's cave, and this, you finish the extradural part. Then we open the dura, and then where you open the dura is important, because it has to be in the subtemporal region, extending from the optic nerve all the way laterally to the greater superficial petrosal nerve. And then you start finding the normal on the other end, the 3rd and 4th nerve, and then skeletonize them and follow them. Then you mobilize them on the side medially. Then you have the resection of the tentorium, because that roof, it is the roof of Meckel's cave, which will lead you to the petroclival ligament and the petrous apex region. And this will give you a guide, because this is where the tumor is safe to remove, behind these areas. Then you look at the intracellular extension, which is between the 2 carotids. And then once you excise the petroclival bone and trim the petrous apex, then you're looking at the posterior fossa portion. And that's where you find the intradural 6th nerve. And to do that, you have to remove the petrous apex. And this is what one big step to me that I feel I contributed to this surgery is how to define the 6th nerve. Because once this was conquered, then we're left with one last battle, which is the carotid artery. Where you find the intradural nerve, you already know where the extradural part, and you skeletonize the 6th nerve. And I'll show a case, some cases where how this is stopped. And then you do the closure which has a dural component, the bony sealing, and the bony reconstruction. All these are important to do. So this is an example of where the growth is. And you can see this is in the lab. Dr. Aboud made a nice model to show how these tumors grow in a way. So this is a tumor which is, if you look here, there's a yellow part behind the petroclival ligament where the sixth nerve comes down. And this is where this tumor was. How do I know? I operated on this case. And then when it grows, it becomes like this. How do I know? I operated on a case like this as well. I'm sorry. So we go by, and this is a larger case. You can see the larger case on the right side. And that's where the tumor extended. You can see extended still under the fourth and third nerve, but covering the V1. But then it starts going around the carotid in this way, and it goes into Meckel's cave. And the entrance into Meckel's cave comes from medial to lateral. That's why these nerves are pushed usually laterally. So you know the anatomy of the pathology. And then when they become bigger, they go into the middle fossa and posterior fossa, like you see here. So this is the growth of these tumors. So when I come to operate, I already have in my mind, like what Michelangelo said, I already can see where the angels are. And then you can carve to bring it out so that when you clean all this, everything becomes more clear. So this is an example of a tumor which was presenting with the sixth nerve palsy, like a smaller one. So if you correlate this with the anatomy, there are steps. Again, I don't have the time to describe all the steps, but it starts with the middle fossa exposure, the middle meningeal artery, because this is where the dura is attached and prevents you from going posteriorly when you do the dural peeling in a way. And then the next steps will be to expose these nerves in different locations. And that's when you expose this region. Now, this area, this is the extradural part. This is where you have to find the oculomotor nerve. You have to find the fourth nerve, the oculomotor. The fourth nerve is coming around here, V1, V2, V3. You have to have a clear picture, but if you notice, the nerves are on the outside. The only one that's inside, which is in Parkinson's triangle, is going to be the sixth nerve. And now we are exposing the carotid. This is the clinodal carotid, and then we'll do the petrous carotid and open it up. Then you start dissecting the nerves one by one. So fourth nerve, you dissect it until where it enters the tumor in the tentorium. And then you do the same for the third, and then you do the same for V1, V2, and you expose them. The next thing you do is, once you get to this part, then and remove part of the tumor in Meckel's cave, then we open, and in a smaller tumor, anatomy is defined. This is tumor here, and there's tumor filling all this area. So we defined the third nerve, cleaned it, and now you see the intradural part. And the intradural, extradural was already cleaned. There was tumor here, we removed it. And now we have to unlock the whole Meckel's cave. That's when we open the next step. This is the tumor, you can see it here. This is Meckel's cave. This is fourth and third. And then this is skeletonizing along the third completely, so we can expose the petroclival junction. Now, once you mobilize them, you get all this exposed. You can see the anatomy clearly, the bulge here. Then we further open the Meckel's cave roof and remove the tumor. This is the nerve in Meckel's cave, and the tumor is medial and pushing the contents laterally in a way. You can see part of the tumor went anterior into the region of the Gasserian ganglion. And then once you remove this part, then we come to the sixth nerve. And the sixth nerve here, you don't see anything, but I can see it all. How? The carotid is coming this way. I already mapped it. This is V1. This is Meckel's cave. So I know that sixth nerve is going to come down. What am I doing here? I find the petroclival ligament that you see here. If I see the petroclival ligament, I know that the nerve goes in anterior to it. Then I have to remove the petrous apex so I can delineate the sixth nerve. And this step, you know, with experience, you know it. So once we clean this and get it ready, then that's when you can see the hue of the carotid. And then once we finish cleaning, that's where I find the sixth nerve. I find it then intradural, and I follow it. This is further removal of the medial part of the petrous apex, and that's the petroclival ligament. Then I'm going to the posterior fossa part, which is behind the clivus and the petroclival region. And then at this stage, all of a sudden you remove everything and you can see the whole pathology in front of you, and the cavernous sinus is completely clean. What is left here is maybe some tumor, in this case, not much, around the carotid. Where is the carotid? The carotid comes from the clinoidal segment, cavernous segment, ascending segment, petrous segment. And it's all, in this case, not too bad at all. And you can see the anatomy. This is the basilar artery here. You can see the whole anatomy. This is why you can see also why, to me, operating on basilar aneurysm is not a big deal, because the exposure I can get, no matter where the basilar, big or small, high or low, we can achieve this. I'm not sure if I can have time later to show you a couple of cases to make the point that operating through the cavernous sinus is important. So imagine if you have a tumor in the pons or a cavernoma, how easy it is to remove it when it becomes on the surface. If you have a hypothalamic or craniopharyngioma involving this area, how easy to remove it. If you have a chordoma that is filling this area, how easy to remove it. So you can see all these elements. This is the sixth nerve on the opposite side. In many patients, I can see the vertebrobasilar junction from this area. Clipping a basilar trunk aneurysm becomes a very easy step. Again, this is the view. Now, what's important in all this is you don't see the brain. This is outside the brain in a way, surgery in the subarachnoid space and in the middle fossa. And this is how cavernous sinus surgery should be done, not going, you know, inside the tumor and trying to find the nerves. You find the anatomy and then the tumor collapses in a way. So I have many examples. This is a very, very challenging case. This is a patient who had retinoblastoma of his eye, in both eyes. He had this eye removed. This is his good eye. And now he developed a delayed, probably radiation-induced meningioma related to his good eye, and he started losing vision. He had a resection of his temporal lobe because at one time he developed seizures, and he had seizure surgery for this. Unfortunate guy. These are the challenges that we deal. I'm not going to show you, you know, the whole details of the surgery, but again, when we finish at the end, I will show you that this is finding the sixth nerve, but I'm sorry, it jumped. And this is the anatomy once we finish, and this is the removal of this with preservation of his. Same as the tumor becomes bigger, it's the same surgery. It's not any different. I will go through the steps here just to show you at the end. And then this is the view we see at the end. We delineate the nerves and they're all well exposed. And then it is really like operating in the lab, but you have to know how things look in the lab. This is the last bit of the tumor being removed from the sixth nerve, intradural, and then we follow it to the extradural back. This is the basilar, the carotid artery in the cavernous portion. This is V1. And this is the carotid clinodal segment. This is the optic nerve. And this is a much larger tumor like you have seen it. And fourth nerve, third nerve. And that's the anatomy all displayed. And if you notice, the picture is almost the same because this is, in a way, the correct surgery. You are operating on the nerves, and then the surgery is all under the brain. It has nothing to do with the tumor. The tumor removal is just like an exercise of the resection. And then you can see the way the nerves look at the end, and the anatomy is all exposed. Similar picture in a way. And then this is how the tumor looks post-operatively. You can see we can achieve total resection in this case. Similar cases, I'm not going to dwell on this, but I will, just for the sake of time. And these patients, if you respect those nerves, they have full function. This is 3 days after the surgery, 3 to 4 days before going home. A lot of these patients don't spend more than, few days, 2 to 3 days in the hospital. So the first thing to conquer was the sixth nerve. And how did we conquer the sixth nerve? You have to know the anatomy of the sixth nerve. This is the ascending carotid. The sixth nerve is really tight around the ascending carotid, and it is anterior to the petroclival ligament under the junction of V1 and the Gasserian ganglion in a way. So then the next thing is to know how to release this nerve because it's tight. There is tumor usually anterior to it and behind it. So how do you release it? It's very much like if you are releasing the optic nerve, if you have a clinoidal meningioma, which is filling the optic canal. What do? You have to remove the clinoid process. And that's what we're doing here. We are removing the petrous apex. Once you remove the petrous apex, then you are releasing the tension. And if there is tumor here, by removing the bone, you make the nerve more relaxed in a way. And then once you do that, at that point, then you can release the nerve, and then you can find it from distal, and you follow it, and you know it is under V1, and that's how you release the nerve. You can see the nerve released, and this is demonstration in the lab of how we do it. So what are we left? We're left with one challenge in this case, and what is it? It is the carotid artery. So this is a young person, and in this case, the carotid was very small in this case. And what happened is these young people who have progressively growing tumors, and you can see that we did a balloon test occlusion, the carotid is already very narrow. And in this case, she passed the balloon test occlusion. So in these cases, to me, you can achieve a Simpson grade 1 resection, which is to remove the carotid. And because they already are sacrificing their carotid, it's a matter of time before they lose it. And then this patient already had cranial deficit. She has a partial third and a sixth nerve. So this tumor is really growing into the cavernous sinus and tightening around the carotid and affecting the nerves. So in these cases, we have to be more radical. So this is part of the exposure, and this is a beautiful picture drawn by Kylie that shows, the details of the anatomy. So this is when the first part of the exposure, you can see the optic nerve, let me get it back. V1, V2, V3, this is the Vidian nerve and the GSPN. In this case, we prepare the carotid. You see there is a tie here. This is around the carotid proximally. This is the distal carotid. In this case, we will achieve radical resection. She's young. Radiation is something you buy, but you cannot sell. So trying to do the right thing for this patient when you can safely do it. So you can see this is the sinus. There was tumor around it. So we did a lot of the extradural part. And this is how the anatomy looks. Then we open Meckel's cave region. And then we tie around the carotid distally. So the next steps will be to clean the Meckel's cave to get to this point. And then now we are exposing the carotid. And we're putting a silk tie around the carotid in here to prepare it. This is the optic nerve that's being cleaned, and the carotid is in this area. And the reason to do that is to release some tumor in the ring and find the ophthalmic artery, and so that we can put the tie proximal to ophthalmic artery. And I usually put a tie, you can put a clip, but the reason I put a tie is to prevent artifact from the follow-up, for MRI follow-up. And then once we clean this area, then we have it all cleaned up and then prepare for the thing. Meanwhile, we are removing the tumor in the tentorium, which is around the third nerve. And then we clean fourth nerve, third nerve, and then the petroclival region is removed because that's where you find the sixth nerve. So the next step, removal of the petrous apex, and then coming down to find the sixth nerve. And then you can see it's like decompression of the optic nerve, and you can see the sixth nerve now being cleaned in a way. Now, this was an important thing for me to find out. This patient had partial sixth nerve. So my question was, if I dissect the sixth nerve away from the carotid, this is the most difficult part in this region, to clean the nerve away from the carotid. So I wanted to know what will happen to these patients, because the sixth nerve was compressed by tumor if we clean it. And afterward, and after cleaning it, and this was the big good news for me, because this is the internal carotid that is all involved with tumor. You can see how it's involved with tumor. We already tied the carotid, and now this is the carotid being removed, and the sixth nerve is here. You will see the sixth nerve is here. This is the carotid. Look how bad it looks. It's all tumor in the cavernous sinus. And once we remove it, now you have tumor behind it. We will clean this tumor, but then the sixth nerve is cleaned. That's where the carotid was, all the way to the superior orbital fissure. The big news here is what happens to the functions of the sixth nerve the way we do it. Now, this is after cleaning everything. This is at the end. And closing it, this is fat that fills all the spaces. And this is the tumor afterwards, completely removed. But what's important here is, after achieving this in this patient, is these are the functions. So this is a young patient who has a Simpson grade 1 resection and with full functions. You gave this lady a new life, and that's very important. So there are many examples. I will not go through them. I will just tell you some of our results. When you look at the oculomotor nerve, I looked at the last 24 patients. We have done pre-op deficit was present in 9, 4 partial and 5 full recovery. This is important because in those patients, 4 of them improved and 5 had full recovery. So if we operate before it's completely damaged, you save them, because the 4 partial, they will have correction with glasses. And the pre-op normal, we have the transient always have full recovery. We have not a single new permanent deficit with good recovery. The same with the abducent nerve is different. Abducent nerve is a problem. This is why for the 24 patients, pre-op deficit is 8, 5 had no recovery, which means if the sixth nerve is damaged pre-op, you cannot recover them even if you decompress them. So you have to operate before. But so this idea that I said earlier, I will wait until the nerve is completely damaged, then I will operate. They don't recover by then. You have to do it earlier. And the trochlear nerve has a very good recovery, obviously, because they are, and this is why a lot of these patients have full recovery of their functions, as you can see. So if you have a normal functioning nerve, it's better chance to get back to normal if you operate earlier. So we have to change this mindset that because I do not know how to operate on the cavernous sinus and I don't feel comfortable to remove the tumor, then, and I know I'm going to damage the nerve, then it is wrong to operate on. You are already making a conclusion based on your capabilities, not on what can be done. So you have to find a person who can do it better and let them do the surgery, because that's what best. So this is when you're waiting for the tumor to mess the nerve, you're saying, don't blame me because the tumor has done this, then it's okay. This is not normal. It's not normal when you are the patient and you want to have something. So how much time do I have more?
As much as you want, I believe, Ben.
How much time? Because I was told that we need to leave time for discussion.
No problem. You can.
No, you can go as
talk.
long as you want.
Okay. Okay. Well, I'm going to show a couple of things. I'm going to show 2 to 3 basilar aneurysms. And now I will show how to go through the cavernous sinus and to reach tumors like this one or aneurysm. But before I finish, I want to go back to the last battle. The last battle is the carotid artery. In this last patient, I was able to overcome and win the battle because we can get rid of the carotid. She's young, she has good collateral flow, she already narrowed the carotid, so you can get rid of it. But what happens when the carotid you cannot sacrifice? This is the battle that I still have to win. And to win this, we have to be able to do a quick bypass. This is, maybe I'm trying to give a hint to Dr. Zubin, because we have to find a solution where we can come with a quick bypass. We can put from the carotid in the petrous region to the supraclinoid carotid, to do it quickly in 5-10 minutes, so that we then we can achieve radical resection almost in every patient. And that's my last battle in a way for the cavernous sinus. So Dr. Ben, you and your young colleagues, you have to help us out here. So we have to find a way.
That's our pleasure.
Yeah, maybe we'll have a visit for you to come to Little Rock and spend time in our lab so we can use your brain to come up with some ideas. So the last couple of things I'll show is a vascular and tumor, which you're not operating in the cavernous sinus, but through the cavernous sinus. If you look at this tumor, it's filling the whole interpeduncular fossa and going down to the pons in a way. And this was a pilocytic astrocytoma in a young person, which means we have to cure this because this patient can have a normal life. So the way to do it is you can go pterional, you can go different approaches, but if you notice earlier how much exposure you can get if you open the cavernous sinus. So what we did here is, these are the steps of the approach, extradural part. You remember I said there is first the bony part, we finished, and now the dissection of the extradural part, and where to start and how to do it and how to understand to save the sinus and the veins. All this is going to be a whole lecture, a whole course, and it's not possible to talk about it. But if you want to learn the cavernous sinus, you have to learn it. Go find someone who's experienced in it. Do not find somebody who claimed they know the cavernous sinus. You have to find somebody who's been in the cavernous sinus. So what I'm doing here is I'm mobilizing the fourth nerve and the third nerve, because I want to open a highway here So the sixth nerve, this is Parkinson's triangle. And now I'm finding the sixth nerve. And this is the carotid here. And now we open this part, but to open it widely, then I have to mobilize the fourth and third. So you open, this is the optic canal, the carotid, and the clinodal segment, because you have to open the clinodal carotid to mobilize the third nerve. The third nerve has a fibrous band under it attached to the carotid. So you can see the carotid now this way. And then the next thing, so we open the intradural part and then open the fissure. You need to see all the elements. And then as we do that, the next thing is to mobilize the fourth nerve and open the tentorium. And then what we do is we open the fourth nerve all the way to the tentorium and the third nerve, unlocking. Now you have fourth and third and the tentorium open. This is the carotid. So what happens here is instead of going between the carotid and the optic nerve to get to the tumor, this is the fissure opened. Then next thing is to open the Meckel's cave and unlock the whole tentorium, because I'm opening a big highway to look at the tumor, because the tumor went to the pons. So now, once I get to this point, look at the tumor here. It's a huge space, which is unobstructed. And this is the fourth nerve, third nerve. So now all the perforators are away. Instead of operating through here, I'm operating from a completely different window. So now the surgery is an easy part. So like I said before, if you look at this tumor, most people will think this is a difficult tumor. It is true, but the difficulty is in not being prepared. If you always have, especially I want to give this message to the young people, anytime you feel it's a difficult tumor or case, think it is not difficult. I am not prepared. How can it become easy? And when you master something, then now I am removing tumor. You see, this is the part of the tumor resection. And then I will delineate everything afterward, dissecting it. And so I have no perforators. The risk is less now. You can see the basilar, the P1 segment. You start seeing it and opening more to go lower until I see the normal basilar. Once I see the basilar, then I go up and expose all this region. And this is how it looks after we finish. You have had an operation through the cavernous sinus, unobstructed, with everything that is risky out of the way. And if you look at the pathology, this is a patient who was cured. This is a young person, she's in her 30s, a pilocytic astrocytoma. So when it comes to basilar aneurysms, let me just pass by. This is. When it comes to basilar aneurysms, again, if you look at the literature, complete occlusion is 93%. It has lower rate, but of hemorrhage and retreatment. So it should be the #1 choice for treating them. But what is here considered most morbid treatment, like it is very, very bad outcomes. Not in our experience, not with this approaches anymore. So to me, the primary treatment is clipping with the right approach. This should be the best option for these patients. We know that it works better than endovascular, but we have to decrease the morbidity. How do you decrease it? By doing the right surgery. Otherwise, you end up with problems like this. Aneurysm surgery, I always look at it as subarachnoid surgery. It is not brain surgery. So you have to stay in the subarachnoid space. And if you master how to navigate it and get the right exposure, 80% of aneurysm surgery is exposure. exposure of all the branches, exposure of everything that goes in and out. So it's a process, it's not a step. You know, if you look, unfortunately, on the internet and you push posterior communicating aneurysm YouTube, you will find the most terrible examples which patients see. And somebody operating, they barely see the aneurysm and they put a clip and sometimes they show how it ruptures. So if you keep treating aneurysms like basilar with the wrong approach, because you see the flow going into the aneurysm makes them grow. This is a lady in her 30s. It's one of my colleagues sent me the pictures, who I have a similar case. This is how I would treat. This is a larger tumor than the one he showed me earlier. And the approach is similar to what we do for the cavernous sinus, except when we get in there, it is easier exposure because there is no tumor. And it's based it's like a little extended pterional approach to the temporal region. So this is the view you see, and you have to unlock this area to expose this region. And then you can take the posterior clinoid if need be. And in this case, we could do PCOM at a perforator-free zone. And this is the view you get of the aneurysm. There is a clip here and a clip here. And look at unobstructed view. Why would I not choose this as the best option if I can do a more perfect clipping for this case? So this is the view you get this in this case. And then you can see all around it. I can see 360 degrees. And you put a temporary clip, and then you have an unobstructed view. And then you can clean the perforators. And then you can prepare where you're going to put your clip. And then apply your clip. You see the aneurysm, and it's being reconstructed. So this is like a process in a way. So by the time we put this, the aneurysm is completely clipped. And the view is open, and the surgery is all done under the brain. So this is the result of this case. This patient is cured. When you look at this patient, unfortunately, she was coiled. Look what happened. 35 years old, and coiled 3 to 4 times. And now what to do? Now this is a difficult case. I want to quote Professor De Oliveira. He used to say, when is surgery superior option? When it's done in a superior level. When you're doing not good surgery, yes, the alternatives are better. So there's a lot of cases that will fail endovascular, and it's inferior if you do the right surgery. One of them is the basilar aneurysm. So if I have something like this, it's going to fail the coiling and the stenting because it has a wide neck, but I can reconstruct it very well. The same with this one. The same with this one. And I have many examples. We have done now more than about 198 patients, and we would just, we'll be working them up. So you have the way it looks like this, but these are the steps. It's a beautiful surgery. It's like operating in the lab. This is the middle fossa. You see how far we go pretemporal, and then opening the dura in the middle fossa, and then going to the further in, all the way to Meckel's cave. And then now we open the dura, open the sylvium fissure, just like Professor Yazagil taught us how to do. And then skeletonizing the third nerve. This is the third nerve. And now you see the anatomy starting to show up. You can take the PCOM in this case. And then the next thing is you are looking at a wide highway, and it's all under the brain in the subarachnoid space. And then by then you can put a clip around the basilar, and then you put another clip if need be on the other side on P1, and then you can start clipping the aneurysm, because now you have a much better view. By the time you put the clip, you can see 360 degrees around the aneurysm, and that's the aneurysm being collapsed. You can see anterior, posterior, you can see fully. And the beauty of all this is you are operating under the brain, all of it. And that's the closure. Larger aneurysm, same thing. You can see this is bulbous and posteriorly projecting. And the same view, basilar trunk, opposite P1. And then we are dissecting. This is ipsilateral P1, 2, and now you collapse. So the aneurysm is shrunken. Now you can see this perforator here. This is where the money is. I can see around it. So aneurysm clipping is not a step, it's a process. Sometimes I do this 3, 4, 5 times, put the clips on, off, on, off. Why? Because I am making a picture in my brain how to put my clips. So the first clip usually is not your smartest clip. We called it, Professor Yazadi called it the pilot clip, which is the first temporary, but it's a permanent clip, but temporarily applied. So your first clip is not smart, but then your second clip, because you can see better, you made the aneurysm small, now you put the smart clip. The next clip is your smart clip. And this one has eyes. The first one was seeing with your brain. Now you're seeing with your brain and with your real eyes. And then once you apply it, you can see the perforator here, you can see everything. Then you take the first clip, which is I'm looking here, I can see the clip is good. The second one, then I take the first one. And now I can decide how to do the perfect clip if need. Maybe this one is good, maybe not. Maybe I have to add another clip. But now I have a much smaller aneurysm, which is, if it was ruptured, it's unruptured, then we can collapse it. You see, I'm checking it, collapsing the aneurysm. And then I look around it and make sure that I have done a good job with the clipping and nothing is included. So in every case, I have 360 view of the whole anatomy, but it is making a good plan to make a big aneurysm, small aneurysm, and you have a safe plan. You see there is a small residual, and then we will put a clip to have a perfect clipping for this approach. So it's the last one I will show is this one is a basilar trunk aneurysm. And you see it's very low. It may look like it's complex, difficult to find, and so forth. But what we did is like that tumor that I showed, the same approach that I did for the pilocytic astrocytoma. The steps is this is like, to me, a relaxing day because it's like working in the lab. This is the 6th nerve, and then you find the 3rd nerve, 4th nerve, and then we open the tentorium, like we have done in that case. This is going through the cavernous sinus, and then mobilizing the 3rd and 4th. And then this is 3rd nerve, mobilizing it and removing the clinoidal dura. Now the next thing is to remove this part, which is the tentorium. I found 6th nerve, the carotid is here, and Meckel's cave is here. So I know all this is okay to remove and save. So I defined all the anatomy. So I will open the Meckel's cave roof and cut the tentorium, follow it. You see, this is petroclival ligament. So 6th nerve is anterior to it. I can cut safely here. If you know the anatomy, you know how to navigate safely. That's very important. So once you open this, then now all what I have to do is to open the arachnoid to find the aneurysm. Look how easy the aneurysm looks. Now it is not a problem. Clipping is the easiest part. But what's interesting is this what's interesting is we found this was a fenestration. There was 2 aneurysms. If you look here, there's another aneurysm behind it. So this would have been missed as well. So that's one beauty about microsurgery for aneurysm is a lot of time you find pathology that you could not have seen even on the angiogram, or you cannot treat with endovascular. So you are really doing a more superior job. Like Evandro said, if you do superior surgery, you get superior results. This part clipped, and you can see very nicely the space. You see the clipping part is it's nonsense, you know, it's the easiest part. Why? Because we got the exposures. In this case, not 80%, 95% of the case was exposure. This is the other aneurysm on the posterior part, and you can see it well. And then we are putting the clip on this part. I put a cottonoid to protect from the perforators, and then you have, now we achieved the perfect result in this case. And the surgery is all done under the brain. So this number is more than 198 basilar aneurysms done in this approach. In this case, we had 3 regrowth in our cases, which is extremely low compared to, and 2 of them we reclipped compared to endovascular, where the percentages is at least 30–40% for basilar aneurysm. The recovery, we published this of the 3rd nerve is full in the majority of patients. And if you look at unruptured basilar aneurysms, our result shows that more than 90% of these patients are doing very, very well. And 96% in 1 year, they are fully functional. So this is important news. So going just to my conclusion here, you cannot go to surgery hoping it will be easy. You have to be prepared to make it easy. This is an important message. If you're not prepared, do not say it cannot be done if you cannot do it. Always go and look for ways to do this. It happened to be this next week, we have a course that we're doing on aneurysms and on microsurgery in general. We have another course in September. As John mentioned, the Dr. Bin Zhu has been to our institute, and pretty soon he will have an invitation because we are planning to do a course on bypasses. So hopefully to see him there so we can get the last challenge in a way. This is our courses are well attended, and this is our lab. This is, I call it, we named it the Osama Al-Mefti Laboratory after my mentor, Professor Al-Mefti. This is our institute, and I will show a little bit of it. It has the Yazergil Neurosurgical Research and Education Center, and this is our entrance, and our courses are usually have cadaver and life surgery. So we have an auditorium which is connected to the operating room, and these are our fellows, and this is connected to the operating room with 3D capabilities. So you can see in 3D the surgery live when we are doing it during the course. Like this coming course, it's 3 days on aneurysms, and we have two surgeries to show. So this is the laboratory. It's a busy place. This is Dr. Zubin. I'm going to put you to work when you come here so we can find the last battle for finding the bypass. This is Kylie, always working hard. You can see him. And this is the Evandro de Oliveira conference room for my mentor and friend, Dr. Evandro, who used to give a lot of his lectures in this room. So you are all welcome, and we hope to see you. And please remember, what we do in microsurgery is a long process that evolves to a moment. It needs a character and an attitude. So when you ask, if you see my surgery nowadays, if I do complex cavernous sinus and it takes, 5-6 hours instead of 20 hours and 12 hours, if you ask me how long did it take, because it's a process that comes to a moment, I can tell you it took 30 years and 5 hours. It's not a short time. So again, thank you for allowing me to share my thoughts about the cavernous sinus. It's an area that is fascinating. We still don't understand well, and there is a lot to add to it in the future, especially the young guys. Always remember two things: there is nothing impossible, and anything that is difficult, it's because you are not prepared. So have no limits to what you can do, but also know your limits. Thank you very much.
Thank you, Professor Krisht. Thank you so much. I still remember 3 years ago, it's also in June, the last day, I enjoyed Professor Krisht's live case, and so engrossed, so I totally forget my flight. I have to change my flight finally. So it's a really beautiful case.
You can,
so,
next time you can
yeah.
change your flight 3 times so you can stay the whole 2 weeks.
So talking to the final battle, I actually cooperate with ENT doctors in these 3 years. I did a lot of high flow bypass to replace the ICA, which was maybe 2 or 3 minutes. I can show you my. So this is for the recurrent nasopharyngeal cancer. So after this kind of treatment, all the patients get the total resection of the carcinoma.
Mm-hmm.
So this is the intraoperative rupturing of the ICA. So we can fix it by the covered stent immediately. So this is a covered stent. And this is a cerebral revascularization use high flow use saphenous vein or radioartery or STA. So sometimes we even need to replace the bilateral ICA. So you can see this is the bilateral ICA was all invaded by the carcinoma. So we have to occlude both sides. So this is a preoperative balloon occlusion test. You can see the ACAM was quite good. So I use the saphenous vein. This is the ECA to SV to M2 segment high flow bypass. Then you can see the bypass was very successful, and I also combined with the 2 STA to M4 double bypass. So this one side triple bypass totally replaced both side ICA. So you can see both side ICA was totally occluded by the coils and the onyx. So then we replace the whole brain's blood supply. This is a PCAM. From PCAM also have some collateral blood flow. So this is a dominant side, which means not only feeded the same side hemisphere, but also the ACA territory. So you can see this is a saphenous vein. Or use some radioartery, or if it's only need to replace the MCA territory, we can use double STA MCA bypass. So for this kind of treatment, we need to sacrifice the long segment ICA. So normally we use coils combined with the onyx. So then the ENT guys, they can totally resection of the tumor under the invaded ICA.
Yeah.
Yeah. So maybe we can cooperate for the last battle of cavernous tumors.
Yes,
Yeah.
Yeah, because in our case, a lot of time I try to save the carotid, but sometimes you find out immediately there that you cannot, and that's why I mentioned a quick bypass.
Yeah.
So we can do it. Yeah. But this is beautiful. Yeah.
Thank
now,
you.
what is the timing you have for these bypasses? When you do the bypass, you immediately close the carotid, right?
Yes, normally we immediately occluded the ICA.
So it stays open. Yeah.
Yeah.
Yeah. Very good.
Okay, Wan Lee,
Hello,
do you
Professor.
want to take over?
Yeah. Hi.
Thank you very
questions
much.
from the audience.
Are there any questions?
Can I have one question?
Okay.
Sure.
Yeah, please.
Thank you very much for your beautiful presentation. My big
Takashi, good
mentor,
to see you. Yeah.
Dr. Krisht. And I remember, do you remember that? When I see your patients who underwent your surgery, camera surgery, I told you, unbelievable. But now I can believe your surgery. And I have surgery for the cavernous sinus since I learned from under you. And now I have 7 cases who had oculomotor palsy, and I tried to recover their oculomotor palsy by surgery, and almost all patients recover all the sudden palsy, but some patients still have the just only upward restriction of the eye movement. Do you have such cases? But of course, there is no problem in their daily life, but just restriction the upward movement.
Yeah. I haven't noticed, to be honest with you, that they have a problem with it, complain of it. There may be very mild, like fatigue at the end of the day. Some patients will tell you, their eye becomes a little bit droopy. Now, the other things to keep in mind is one of the reasons is if there is any injury to the periorbita on this, when you expose the optic roof, and then because preserving the periorbita prevents adhesions with the superior rectus, and that probably these are the things which I think of in past, like meningiomas invading the superior part of the orbit. When we remove them, there is some scarring between the tissue in the epidural space and that area, which causes weakness where you cannot lift the eye up because it's muscle weakness, not nerve weakness. If the other parts of the nerve are working, then it is most likely not because of the nerve, it's because of some muscle scarring, or and usually if the periorbita is preserved, it shouldn't be a problem. If there was more adhesions, it will. Now, more recently, I have been using amniotic sac from like newborns. There is an amniotic sac that we use it on the brain to prevent adhesions after gliomas, so that we don't have to come back to scar tissue and everything looks perfect, like a new case. And those are the cases which I thought about in the future to use, put a layer on the periorbita if it is disturbed, to prevent adhesions. But those are the thoughts. You may want to go back to your videos and look at the periorbita in those cases if they are different from the others. That's what I can think of.
Okay, thank you very much.
You're welcome. Good to see you, Takashi.
Thank you.
Okay, thank you again, Ali, Chris.
Thank you.
Hope we can.
Dr. Anas, you raise your hand. Do you have some question?
Firstly, thank you very much, Professor Ali Krisht. You are wonderful as always. We met together in Germany in 2016.
Yeah.
I have registered for the next course in Arkansas, but unfortunately I didn't have the visa, but I will continue to have this in September. I have only how you can determine the petroclival ligament, and when you open the dura, there is a point how we can open the dura. And what about the oculomotor system? And when you drill the posterior clinoid for the transcavernous approach for clipping of the basilar aneurysma, this is very important. How you can, that's mean when I decide intraoperative to do a posterior clinoidectomy, when I can do that without posterior clinoidectomy.
Yeah.
To more exposure.
Yeah. For the first one, the petroclival ligament, you really have, Anas, to do a lot of cadaver dissections to become easy to find it. But if you are not comfortable, the best thing to do is you go where behind the Parkinson's triangle, and then in these tumors, the dura of the petrous bone is always preserved. So there is tumor anterior, which is in the cavernous sinus, and posterior, which is in the against the brainstem, and there's a dura in between. And if you find that dura and you dissect from there to anterior, you will meet the petroclival ligament. Now, you have to be careful. There are variations. Sometimes it's calcified in meningiomas, and it's like a bone, like a ridge of bone. And sometimes it is nice, like a ligament, which is clearly seen. And sometimes it's very small to where you may cut it without knowing that you're there. But if you go more medial towards the petrous apex and more lateral towards the clivus, then you can see where it is most thick, and then you follow it to the middle. And in the middle part, middle lateral part is where just anterior to it is where the sixth nerve comes down. So usually if you know, you identify, usually what I do is I identify the fourth nerve and V1, and then inferior to this triangle and go posteriorly, you find the dura, and then you dissect anteriorly, you will find the petroclival ligament for that. For the other question, the variations in the anatomy of reality compared to pictures is huge, which means you can look preoperatively and say, okay, I am going to not remove the posterior clinoid because I can reach the petrous, the basilar trunk, and I can put a clip because the CTA on the sagittal view shows that this aneurysm is high. You will go in there and you find you're mistaken because some patients have a small incisura and then you don't have a lot of space. So you decide then you have to open, and sometimes you just open the petroclival dural fold behind the oculomotor trigone is enough. But some others you have to remove it because how the anatomy intra-op is different. So you just have to be prepared in every case. So you just peel the dura and remove the bone. I used to drill it in the past. Nowadays, most places have the sonopet, which is the bony CUSA in a way, or bony ultrasonic aspirator. It's safer to put it in there and remove it. So you have, when you go to operate, you have to know how to be prepared for variations of anatomy. Because if you go there and you only know one approach and one step or few steps, then you're going to call it a difficult case because you are not prepared, like we said earlier. But if you go there and you have all the weapons in your hand, and then when you encounter the problem, you say, oh, okay, no problem. I will remove more of the clinoid, more of the clivus, more of the dura here. And then all of a sudden you have a big approach. You cannot go into a case with limited options. You know, there's a lot of colleagues, they will show you, oh, I can do this surgery from a small keyhole window, this and that, and so forth. They want to say they are kind of big surgeons, important and macho and everything. It's nonsense. It's stupid to be talking about small craniotomy or big craniotomy. You need enough craniotomy, and you have to have enough steps to make the operation easier. This is not about that, you know, I can show you cases myself that I've done in a very small window, but it was the perfect case for it. Favorable anatomy, shrunken brain, wide spaces and everything. It is not right to take one case, which is easy, and go to a meeting and show, oh, look, I can do this from a small pterional approach. Well, you can do it that day, but tomorrow you will not be able to do it. So as long as you go to the lab and get everything you can learn, and then you choose how to use it. You know, you are like a soldier going to fight an enemy. When you go as a soldier to fight an enemy, you don't take a knife only, because if the enemy has a machine gun, that's it, you lost. But you go and you take all the equipment you need to be prepared. I hope I answered your question.
You answered a lot for my question. Thank you very much. But I have the last simple question. When you see that we have to do a frontotemporal-zygomatic approach for to remove the lesions of the cavernous sinus, or to go more deep to the prepontine cistern?
When do you need the cranio-orbito-zygomatic approach?
Yeah, FTOZ.
You know, it has variation. Again, there are too much discussions about, do you need to remove the orbital rim or not? Do you remove the zygoma or not, and so forth. I don't care. You know, if you can remove it and put it back, it's okay. You know, if it makes you comfortable. You know, when you're younger, you tend to want to be bigger exposure. Sure, because what is important is for you psychologically to be in your best shape. If you remove more bone, so you feel good, and then you're going to remove the tumor better, that's okay. You know, I'm not going to criticize you. Even if I do it differently, I'm not going to say you're wrong. You know, there's too many wasted discussions about these things. You have to be, as a surgeon, feeling good, and you feel like I can win and I am going to do well. Whatever brings you to this point, it's okay.
Okay, on the last question, anterior petrosectomy, combination with anterior petrosectomy with your approach, when I suggest to do that?
I can tell you, I don't do it as much,
okay,
because with my approach, for most lesions which are more medial, if you come from a medial approach, most people who do a petrosectomy is because they go subtemporal. If you come subtemporal for a medial pathology, you cannot see it. If you come more anterior, then you are coming down on the pathology. You see what I mean? A trajectory changes. So if you come from lateral, you know, you have to remove more of the petrous bone to see it, because it's very much like I will show you my finger. If you look at my finger here, you know, if my finger is here, you know, it's not in the way of my eyes, right? But if my approach is like this, then I have to cut my finger to see, right? But if my approach is here, I leave my finger. I can get to this point.
Okay, thank you very much. I have to
You're
another
welcome.
question, but thank you very much.
Well, when you come to the course, and hopefully we'll help you out.
I am very happy to see you, and I try to do a fellowship with you as a master of the transcavernous approach all over the world, as a student of Professor Yazargil, the father of the microneurosurgery.
Yeah, thank
I
you
am
for your
very
kind
proud.
words. Thank you for your kind words.
Okay.
Thank you, Professor Krisht. So
Uh,
tonight, actually it's your morning. We have 1,500 audience in the WeChat.
Oh my
Listen,
goodness.
watch your presentation. Thank you.
Thank you, and thank you for everybody, and I hope I was useful for everyone.
Okay.
Thank you.
Dr. Krisht.
Thank you.
Okay. We hope we can have more chance to communicate with you face to face.
I hope
Okay.
so too.
Thank you. So now we have our next speaker from mainland China, Beijing Tiantan Hospital, Dr. Shaolin Chen. And today he will introduce a new breathing system for the subarachnoid hemorrhage, aneurysm outcome. It's called TAPS score. So, yeah. Please. You can share.
Thanks for Professor Zhao's introduction. And it's my honor to follow in the Professor Ali to give my speech. And today I give a topic about the ruptured aneurysm. And the topic is the 90-day prognosis model based on the early brain injury after aneurysm rupture, the TAPS score that we call them the TAPS score. Okay, so and this is our team member and Professor Jidong Zhao, Professor Wan Shuo, Professor Yuanli Zhao is my mentor, and there's three research topics in our research team. One is the neurocardiology, and the other is the aneurysm rupture, the aneurysm subretinal hemorrhage, and the third is the AVM cases. And as you know, the aneurysm rupture, the aneurysm hemorrhage, the incidence rate is about 5% to 7%, and it remains the high morbidity with the high mortality. Even nowadays, we have many new techniques for the treatment for the aneurysm. And for the diagnosis methods, the CT be used for the diagnosis of the hemorrhage. And CTA and DSA be used for diagnosis for the aneurysm. And treatment modality that could be divided into surgical and endovascular coring. So from 2020, we begin our database of ruptured aneurysms, subretinal hemorrhage in our hospital in Beijing Tiantan Hospital. And this database was registered in the clinicaltrial.com. So we call the name the long-term database that we used in our Tiantan Hospital. And nowadays we have published about 8 papers from this database. We published the JNS about the hospital complication related risk factors with the outcome. And also with another paper about the prognostic model about for the 90 days to functions, and update on the anti-oxidative stress on the early brain injury. Also in our patients, we use the ICP for almost every emergency cases. So we have published another paper about the use of ICP that under ICT monitoring that help to improve the outcome of the treatment. And also nowadays, all of the patients in our department, in the emergency department, the patients have the multimodality CT scan that include the non-contrast CT and CTA and CT perfusion. And in our hospital, we use the rapid software to get some CT perfusion parameters. So then another project is about use the CT perfusion to detect the pathology and the outcome of the aneurysm rupture. Or something, yes. So nowadays, we have 2,162 cases in this long-term database from 2015 to 2021. And today, this the project about the first paper I want to introduce today is the in-hospital complication-related risk factors for discharge and 90 days outcomes. By comparing the surgical creeping group and endovascular creeping, endovascular chlorine. And in this project, the surgical group, after the PSM, surgical creeping, there's 329 cases versus endovascular chlorine, also the same number, 329 cases. And at discharge in 90 days, we compare these two groups by the MIS. So see the picture, the up one, the MIS 0, there's difference between the surgical group and endovascular group. And also the MIS 1, the same. At discharge, that is the functional is the difference between the two groups. For the 90 days, also the difference between the surgical creeping group and the vascular chlorine group. And we use I try to find the complications related to risk factors for this kind of two group of treatment. And we found that for the surgical creeping group at discharge, pneumonia and WFNS grade 4 to 5, the DCI, anemia, age, abnormal hepatitis function, modified facial gland, and venous thrombosis are related with the unfortunate outcome at discharge. In 90 days, there is the parameter, the variable is the pneumonia, WFNS grade 4 and 5, high grade 4 and 5, ECI, and age, modified facial grade, and abnormal hepatitis functions. That's for the surgical creeping group. And also for the endovascular chlorine group, we also find some variables that related to the bad outcome. And the common independent risk factors is WFNS grade and age, in hospital pneumonia and DCI. And also in this project, we found that complications have a linear relationship with the financial burden, no matter what for the surgical creeping group and also in the endovascular chlorine group. So this is the first panel study. And now the next, what happens to the brain after aneurysm, hemorrhage, and how to predict the outcome. That's what we think after the first project. And there's one concept that we need to say here that we call early brain injury. Early brain injury that was introduced in 2004 by Professor John Young. And he explained the acute pathophysiological events that occur in the 72 hours after the hemorrhage. So there's two curves that we can show what is the relationship for what is the important for the early brain injury. The up picture shows the early deaths after the hemorrhage. And most of the early days happened in 3 days after the hemorrhage. And for the lower picture shows the early brain injury. And early brain injury also have a higher level in the 3 days. So that's a coincidence. And the EBI stage is a major period of patient's death. And the mechanism of the EBI is the leading cause of patient death. So in the non-clinical, it's very important to find the mechanism for the EBI and try to find the treatment strategy for the EBI. And what is the EBI? EBI that causes the brain damage by SAH, and including blood release accumulation, acute reactive hyperemia, cancer and cerebral ischemia, systemic complications, also with some other organs dysfunctions by the hemorrhage. So nowadays many paper published about the EBI's mechanism. And so interesting is that the mechanism of the EBI, all of them are related to the pathophysiology of the SAH, such as the DCI, such as some inflammations, dysfunctions, also with the bad outcome for the SAH. So which EBI indications are commonly used and easily available in clinical practice? That's another project that I come to my mind. And see this picture so completely wonderful, showing the EBI and mechanism of the EBI that shows higher increased ICP with decreased CPP, and also with the impaired cerebral autoregulations. Neural self-death cause the BBB breakdown, and also cause some microthrombosis and microcirculatory failure. And see, after the with the definition, we can find there's 4 experts in the clinical applications. The first one is the clinical symptoms and signs. For such, hand grade 4 and 4 and WFS 4 and 4, also loss of consciousness and with the neural worsening. That is these 3 experts is closely with the EBI. From the neural imaging, including intracranial blood burden, global and focal cerebral edema, and also with the ischemia lesion load. For the invasive neural monitoring, including brain tissue hypoxia, mechanical distress, and some axonal injury or spreading depolarizations. And the final expert is inflammation. Inflammation, including 2 experts. One is the brain inflammation, and the other is the systematic inflammation response. So in our mind, I think there's some kind of variables that related to the EBI, such as clinical symptoms and signs, Glasgow Outcome Scale, WFS grade, hand grade, earlier loss of consciousness, and early seizures. For the neural imaging, facial grade, modified facial grade, GRIP score, CPRS group, and acute hydrocephalus, maximal diameter aneurysm, and location of aneurysm. And inflammations include white blood cell, mononuclear something, and others such as the glucose, hemoglobin, something like that. So for this project, I try to find the EBI variables that related to the bad outcome, to the outcome, and try to set a model that can be used to predict the model, to predict the outcome. That's the inclusion criteria. The patient 72 hours after the onset of hemorrhage that we include in our project. And that's all the cases, about the 933 cases. These patients were divided into 3 parts. One is derivations cohort, number is 640, and the other part is a validation. Validation cohort is 185, and the third is a prospective cohort. We use the univariable and multivariable analysis and try to set up a score to evaluate the outcome. We developed the scoring system based on the beta coexistence and use the discriminations to evaluate the outcome. There is the table, all the variables that we used in this product. And for the age is the difference in the subcategory difference. And for 90 days outcome, were divided into two parts. According to the MIS, 0 to 2 is the favorable outcome, and the MIS, the more than 2 is the unfavorable outcome. Finally, six factors were independent associated with the bad outcome. There's age more than 55. WFNS score is 4 or 5, and modified facial grade 3 to 4, and grip score 5 to 12 scores. WBC, higher WBC level, and surgical gripping. And in my project, in this cohort, the surgical gripping is a bad factors, is the risk factors for the outcome. And now we use the better coefficients. We set up a TAP score, age, WFNS, modified facial grade, and grip, WBC, and surgical gripping. The total scores is 7 points. And now, we compare our TAP scores with the other 5 models. The famous critical model in the literature is Sahi, Fresh, Hair, and Professor Mao. Professor Mao coming from Huashan Hospital. He published a score in 2016, and Professor Lai. And for Ticker A, our derivation cohort, the TAPS AUC is about 81%, and the Sahi is about 80%, and Fresh is the 78%. For the validation cohort, Sahi, the AUC about 87.2%, and our TAPS score reached 81%. For another cohort, for the prospective cohort, Sahi AUC approached 85%, and our TAPS score approached 80%. So from these 3 cohorts, it seems our TAPS score is about more than 80% to predict the outcome. And another table shows that our TAPS, we use the age. Age is the demographic information. And we use the WFNS, is a clinical data. WBC is a laboratory test. And we use the grip, modified facial grip is imaging information. And finally, the final factor is treating, the treatment. The treatment that is the treatment modality. So in our TAPS scopes, we use these 5 experts to describe, to set up the critical model. And among these models, only our TAPS model emphasizes the importance of preoperative inflammation biomarkers. Because nowadays, more of the paper and more research have focused on the inflammatory information about the rupture, SAH. So in our TAPS scopes, we use the WBC. We found the WBC is a risk factor for the outcome, for the bad outcome. And also in our scopes, we use the grip scope to evaluate IVH intraventricular hemorrhage. That will be more precisely. So, but the current understanding of EBI is still limited. I think we need more basic research with the clinical applications. That we need more translational medicine research results to show to give us more about this mechanism of EBI. So some limitation of our study. The first, I think the predictive model requires further external validation in large multi-center study. So you're welcome to join our project to evaluate these scores. And second, when comparing different models, the results cannot deny the contribution of the original study because the different models target slightly different populations and outcome events. And finally, the EBI indications are commonly used and easily available in clinical practice. Of course, some other EBI indications from the basic research may improve the model's discriminations. So as the research improved, we can find more, we can know more mechanism about the EBI, also with the aneurysm of the family. So my future, there's some idea come to me. I will set up a SAH calculator as the paper published in the 2020 scope. That we will use our TEPS scope to set up a SAH calculator, and that for every patient that we can get the detailed the outcome evaluations use our scopes. And also we can use the AI predictive model, because the AI, based on the AI technique, maybe have to improve the sensibility for this model. So thank you for watching, and welcome to join us to share light on the secret of aneurysms of hemorrhage. Thank you, everyone. Thank you.
Thank you, Xiaoling. Okay, so are there any questions from audience in regard to Xiaoling's talk?
I would like to comment. Thank you for the talk. This is Dr. Krisht. It's interesting, these findings, because we've always believed that subarachnoid hemorrhage is really a disease, not only an event. And that shows with the findings that that this is more than what we see, and we assume it's only a bleeding and that's it. So, and this is important to relate to the family when they first come in, that this is a long process. And to me, subarachnoid hemorrhage and its effects is not only after surgery and after a week or two. It's a process that takes 2 to 3 months to clear. And the subarachnoid hemorrhage, it clogs the brain, and to me, the spinal fluid circulation and the ventricles is the lungs. They're the lungs of the brain. And when you fill them with blood, the brain cannot breathe, and it starts leaving all these toxic stuff inside the brain and leading to the outcomes that these patients have. So this is why I am one of those firm believers that if we can do a very high level surgery that can get rid of an aneurysm, or even if it's endovascular, but you choose the right aneurysm to treat, not to treat the ones which can recur, the best treatment for aneurysm is to prevent them from bleeding, because once the bleeding occurs, as shown in this paper and in our experience and in other papers, it's a completely different animal, completely different disease. We cannot assume it's just a blood vessel that leaked. It's like a flood. If you have a flood of water, like a river which flooded, it destroys a whole region, and it's not only making things wet. So thank you very much.
Thank you, Professor. Thank you for a good comment. Thank you.
Okay. Are there any questions? Oh, okay. It's almost 10 p.m. Today we have 2 hours for the whole webinar. Okay. So I think it's time to finish this webinar. And we hope another one after 2 weeks, still Sunday night, 8 p.m. Beijing time.
Right. We don't have the schedule yet, Wan Lee, but we will have it. But I would like to mention a couple of things on the neurosurgery news in China. We're going to start a neuroanatomy lecture series by Victor Hugo Perez. It's going to be in English, but it's going to be translated into Chinese. And I would like to introduce Victor. Hello, Victor. Victor is a noted neuroanatomist from Mexico. Go ahead, Victor.
Hello.
Hello, Victor.
Been very nice to see you.
Nice to see you.
Thank you for this kind invitation to speak. I think little lectures about surgical anatomy of brain and also spinal cord. As you know, I have been working for almost 30 years surgical anatomy of arteries and veins of brain and spine. So thank you so much, Professor Bin.
Can you quickly show a screenshot of one of your dissections, Victor?
Yes, yes, I can show.
Just very quickly,
This one, can you see it?
Yes.
Yeah.
Okay. Let me put this in the whole screen. Okay. For example, this is a dissection of the interhemispheric fissure. Just let me. Okay. Now again. Okay. These are some brains. I have injected these brains with latex in order to show the surgical anatomy. And in this case, I didn't find a true anterior communicating artery. Instead, these anterior cerebral arteries join in this portion of these arteries. So I think, as Dr. Ali Krisht said, it's very important to know the anatomy, the vascular anatomy of the brain, in order to have the opportunity to do a better surgery. So I think this is what I want to show you in some lectures.
Okay, Victor. Okay, Victor. We'll let everyone know by what Neurosurgical TV. Just keep watching the website. And thanks everyone, Zialin, Ali, Wanil, and especially Ben, for putting this all together. And we'll see you in 2 weeks. Thank you very much.
Bye-bye.
Professor Bin, bye-bye.
Bye-bye.
You again. Bye.